Hello, and welcome to another episode of Cardiometabolic Beat, brought to you by the Cardiometabolic Health Congress. Today, we have the pleasure of speaking with Dr. Ken Cusi. He's the Chief of Endocrinology, Diabetes, and Metabolism, and also the Professor of Medicine at the University of Florida. Today, he talks about the impacts of NAFLD and NASH and the approaches for screening, diagnosis, and treatment. Thank you so much for joining us today, Dr. Cusi. Now, I'd like to start off by asking, why should we be concerned about NAFLD and NASH? And why are we seeing increased interest in NASH in patients with diabetes or cardiometabolic risk in recent years?
Well, Melissa, that's a great question because I think that all know from just reading the newspaper, watching the news, that obesity continues to be on the rise, particularly in some ethnic minorities. And this has led to also a continued drive of more type 2 diabetes. So these are two conditions that are characterized by insulin resistance. And this is a major driver for the liver accumulating fat, and in those genetically predisposed to develop NASH. So NAFLD is an umbrella term that goes from the spectrum of just having fat in the liver to the steatohepatitis that can lead to cirrhosis. And NASH is when you can confirm that on a biopsy that shows that you have this damage. Now, why it has gone up is because we have an aging population, we have a rising of risk factors, which the two most important are obesity and type 2 diabetes. And because we now realize in guidelines like the recent American Association by Clinical Endocrinologists guidelines and clinical care pathway developed by multidisciplinary groups, that there's something we can do to screen them and to treat them now without have to be waiting until they come with cirrhosis to the liver doctor.
Wow, that sounds very scary. And you mentioned screening. What would care physicians, cardiologists, and endocrinologists need to know to look for while they're screening for these things?
Well, what they have to do, number one, is be aware of what are the high-risk groups. And we now have a good idea of which these three groups are. So traditionally in medical school, they tell you that if your liver enzymes, your plasma aminotransferases are elevated, that something is wrong. So that's a high-risk group. Also, if we identify liver fat on any imaging that we do for other reasons sometimes. That's the first group. The second group is the highest risk group for developing cirrhosis, that are people with prediabetes or type 2 diabetes. And we think that having the most severe insulin resistance typically predisposes them to a number of factors that we don't understand very well, but end up causing liver fibrosis and eventually cirrhosis. By the way, NASH also predisposes to hepatocellular carcinoma. So that has been the link over years. We were wondering, why do people with type 2 diabetes develop more liver cancer? And NASH is that link. Finally, the third group is the other obvious group, those with obesity and metabolic syndrome or insulin resistance syndrome that have, hypertension, atherogenic dyslipidemia, central obesity, and so forth. So all have to work on it for two reasons. Number one, if you never develop cirrhosis, but you have just fat in your liver, we know that this is associated with increased cardiovascular risk. And although the studies have not been conclusive, there are a number of possible pathways like more atherogenic dyslipidemia, more hypertension that can lead to that. Also, the fat that accumulates in the liver accumulates in other organs. This ectopic fat is caused by very unhealthy adipose tissue, and that doesn't respond to insulin normally. So you have free fatty acids in the blood that tend to provide the basis for fat accumulation, triglyceride accumulation in the liver, and also in the myocardium, and even in beta cells that we think predispose to type 2 diabetes. So very important that today we identify these high-risk groups and treat them, because there are treatments that can work.
Okay. And for these high-risk groups, are there any current treatments that we can address these with?
Of course. So who to treat? So number one, what we do is we identify them not just by liver enzyme, that only, like we did a screening study that we published in Diabetes Care 2021, and only about 10% of overall people with type 2 diabetes going to the routine visits have elevated liver enzymes above 40. But 1 out of 6 had moderate to advanced fibrosis. So in those individuals, what you want to do is a FIB4, that is a diagnostic panel that is composed of putting in an equation your age, your liver enzymes, and platelets that go down if you have cirrhosis. That's the first screening test. The second is to do an elastography test to see if the liver has fat and fibrosis. When we identify the high-risk group of people, there are treatments. Number one, lifestyle. That's the core of the management of obesity, diabetes, and also fatty liver disease. By the way, there are lean individuals that can have NASH, and typically we find that they're also insulin resistant. So it's not only obesity causing insulin resistance and NASH, you can have a genetic background for insulin resistance. So insulin resistance is a promoter, but there are other pathways in the liver that we don't understand very well that will cause the inflammation and cause the fibrosis and cirrhosis. So treatment, lifestyle, weight loss by any means, just lifestyle intervention, bariatric surgery, and medications. Last year, we've had for some time liraglutide for the management of obesity. Last year, semaglutide at 2.4 milligrams was approved for the treatment of obesity. So those are options to help weight loss and other weight loss agents that we're already familiar with. If you have type 2 diabetes, there are options like, again, GLP-1 receptor agonists, liraglutide, semaglutide have shown to be effective. Other GLP-1s have shown to reduce liver enzymes and liver fat. So weight loss, primarily, that seems to be working. We and others have done a lot of study with pioglitazone, which was Actis. Now it's a generic medication that should cost less than $5 or $10 a month. Pioglitazone, we start at the lower doses of 15 milligrams, and then which doesn't cause weight gain or maybe 1 to 2%. And then you can increase it to 30 milligrams, and that's probably the dose where you want to keep your patients. Of course, you don't give it if they have a history of bladder cancer, although most studies have been negative, and we watch for bone loss in the long term. So GLP-1 receptor agonists, pioglitazone, and weight loss by any means.
Thank you so much for sharing those. With all that's going on with the NASH pipeline, do you see hope on the horizon for any agent to be FDA approved soon?
Well, yes. And I have to say, we talked about pioglitazone last October. There was a study with what we call a PAM-PPAR. That's a PPAR alpha, gamma. And again, pioglitazone is primarily a gamma with some PPAR alpha activity, and delta that seems to be anti-inflammatory. In the New England, they published a short 6-month study showing efficacy against steatohepatitis and fibrosis. So they're doing now a big phase 3 study. There was also a publication with semaglutide in the New England that came out in November 2020, published in March. So those are effective, promising agents. Then there are dual agents like GLP-1 and GIP receptor agonists like tirzepatide. Many of you have seen the SURPASS study showing great efficacy in weight loss, controlling diabetes, and improving the cardiometabolic profile. And there's a rich pipeline, like 50 compounds. There are thyroid hormone receptor agonists, FGF21 agents. There are new direct AMP kinase activators. There have been FXR, beta-cholic acid has had some problems in getting approved, but there are others. Maybe that one will get approved, but most likely not. And there are a broad spectrum of agents being tested, others that are also insulin sensitizers. There's a dual GLP-1 glucagon receptor agonist that's also undergoing studies in NASH. But we have to say that it'll take 2 or 3 years until these studies are completed. But it's important that the clinician know that there are things you can do today with diabetes medication. I forgot to mention vitamin E that is shown to be effective in people without diabetes in the PIVENS trial, published more than in 2010 in the New England. But it has been clouded a little bit by some unanswered questions regarding prostate cancer and maybe an increased risk of cardiovascular disease. But I think larger studies are warranted. We did a small study combining it with pioglitazone, in which pioglitazone was effective with it. Vitamin E was less effective. But again, more work is needed in that field. And pioglitazone also works in people without diabetes, but again, it only has an indication for people with diabetes. And I have to tell to the audience that there are no FDA-approved medications. So although diabetes medications like pioglitazone and semaglutide work, they are only approved for the treatment of type 2 diabetes, or semaglutide also for obesity.
That's very insightful. Thank you. And how do you see the future of NAFLD and NASH, both in terms of diagnosis and treatment?
Well, what I see are several things. Number one is that it's going to be incorporated into our diagnostic guidelines. We just finished, and it's in press, that first guidelines for endocrinologists by the American Association of Clinical Endocrinologists, co-sponsored by the Liver Society, the American Association for the Study of Liver Disease, and where we're going to ask endocrinologists to screen with the FIB4, which doesn't cost more than your routine labs, all people with diabetes. And once you can put them in the risk, if that number is less than 1.3, you're probably okay. But if it's above 2.6, you send them to the liver doctors. And in the middle, you order some other tests. So FIB4, elastography, and multidisciplinary teams are going to get most of our people to be diagnosed earlier. Once we diagnose them, and again, we talked about obesity and cardiometabolic disease patients, metabolic syndrome patients, and also those elevated liver enzymes, they should be sent to, once we stratify them as high risk based on the FIB4 and elastography, the most commonly used test is FibroScan. There's also shear weight elastography. But once you think that you have somebody with intermediate or high risk, as you put in that ACE guidelines, we need to send them to the pathologist and work with them. The other thing that's going to happen this year is that the American Association for Study of Liver Disease is going to update their 2018 guidelines. I was the endocrinologist in the prior two guidelines. Now we have Dr. Barb from also University of Florida helping them. And that's going to update a lot of what we want to do. But I think the call for us as cardiologists, I'm an endocrinologist, primary care doctors, is to begin thinking about NASH, increase the awareness of your patients, and treat them now. Lifestyle, weight loss by any means, pioglitazone, or a GLP-1 receptor agonist. That's the way that you're going to prevent people from developing cirrhosis, and that's something you can do now.
Thank you for those very helpful tips. Do you have anything else you'd like to share with our audience today?
I think it's an exciting time. We hope that the ADA and the Endocrine Society are also going to, I think they will this year, embrace broader and more active participation in the screening of people with at risk. And there's things we can do today. We just need to be aware of it. It reminds me when we began screening for cholesterol or osteoporosis. There are things we can do. We need to incorporate it into our management of people with obesity and diabetes. And I'm sure that in the very near future, we're going to have drugs that are FDA approved to use in combination with the current agents. So thank you, Melissa. It's been great to cover these very interesting questions that you made.
Well, thank you for your time and expertise. We really appreciate it.
Take care. Have a great day.
You too. Thank you. If you have any questions or if you have any feedback on topics you'd like us to discuss in the future, we would love to hear from you. You can email us at info@cardiometabolichealth.org, or through social media via Facebook at Cardiometabolic Health, or via Twitter and Instagram at CMHC_CME. Thank you, and until next time, have a great day.